Good afternoon, ladies and gentlemen. The Maryland Healthcare Commission meeting will now come to order. Fellow commissioners, included in your packets are copies of the minutes from the March 15th public meeting of the Commission. You've all had an opportunity to read the minutes. I would like to entertain now a motion for approval. One motion. Do I have a second? All those in favor say aye. Ayes have it. Okay, very well. Commissioners, you've all received written updates from our various centers. You've had an opportunity to read these updates and absorb the information available on various things that our centers are doing. Commissioners, do any of you have any questions at all on the written updates for any members of the center, any of our centers? Ben, do you have an update?
Thank you, Mr. Chairman. I have several updates. The first is an introduction. I wanted to formally introduce Megan Renfrew to the Commission. Megan comes to us from most recently with Cognosante, where she headed innovation unit at that health IT company. Prior to that, she served with the Centers for Medicare and Medicaid Services, and she also spent 5 years with the Office of Legislative Counsel at the House of Representatives, the nonpartisan legal support organization for the House. So she brings to us experience in bill drafting, experience with working with a major federal partner, and knowledge of some of the health information technology innovations that are occurring across the country. Welcome.
Megan, thank you very much for joining us.
Secondly, I want you noted that Megan just joined us over this legislative session. We limped through the process, and I wanted to recognize the staff that really played major roles in our during the legislative session, starting with Diane Arnold, who again, in addition to always monitoring legislation that affects the Commission, worked with Bridget Zumbro to make certain that our fiscal analyses were submitted, monitored our legislative responses, and sort of kept me on task when I tended to drift off. I really appreciate those people's work. I also want to recognize the work of the senior staff, David Sharp, Tressa Lee, and Paul Parker, participated in various legislative hearings, very much appreciated. Our attorneys, Sue Ellen Weidman and Sarah Pentley, were extremely active in providing advice to the staff on actions that would affect the Commission. So very appreciative of all of their work. We certainly couldn't have accomplished what we did this year without everyone pitching in. You have a rather extensive update from the staff on our activities. I just wanted to cover two other areas of broad statewide import. First of all, on the total cost of care model, some of you are monitoring that very closely, others from some distance. That process continues. There have been early drafts submitted to our colleagues, HSCRC. Commission staff have had opportunities to look at those. We know that another version, not for public dissemination, but for internal review, will be shared over the next several weeks. And of course, part of that total cost of care agreement includes provisions pertaining to the Maryland primary care model, which is a key element of the overall total cost of care demonstration. We are monitoring those changes particularly carefully. As some of you probably know, the TCOC demonstration itself could launch as late as January 2020. The primary care model currently is slated for release for launch in January of 2019. As the review process goes forward, we will be monitoring just how much of a window we have between approval of the primary care program and the application process that has to take place in order to engage what are called care transformation organizations, which are organizations that will be supporting the primary care practices as they move to a more advanced level of care, and also the primary care practices themselves. We know from the CPC Plus program, a CMS program that was launched in 2017, that a 6-month window is sufficient, but it is barely sufficient. So we will be working with our partners at CMS to try to move this along in a way that both the care transformation organizations, the CTOs, and the primary care practices have an appropriate window of time to apply, review participation agreements, and gear up for a January 1, 2019 launch. It is an ambitious project, and the department who's taking the lead with MHCC support obviously wants it to go off as smoothly as possible. The second piece of information, many of you know, in terms of healthcare, the centerpiece of the legislative session was bipartisan legislation that established a reinsurance program for the state of Maryland. The Commission does not have a direct role in the establishment or administration of the program, but we do provide information to the Health Benefit Exchange on the status of the individual market. We will be providing some additional information during this preparation period. It will be relatively short. The state has committed to submitting an application to obtain federal program approval for what is called the 1332 waiver that is essential to establishing the reinsurance program by July 1. We want to meet that deadline, but there will be a comment period for interested parties over the next several months. I will share with you the draft application over the next day. It is already posted on the Maryland Health Benefit Exchange website. I think it's important to note that this is really essential to stabilizing the individual insurance market, both from the standpoint of the on-exchange market, but also those who purchase individual market off the exchange. In Maryland, about 150,000 people purchase on the exchange, and roughly a slightly smaller number purchase in the individual market off the exchange. The major discriminator is that if you purchase off the exchange, you're not eligible for the various subsidies that the federal government has made available through the ACA for purchasing on an exchange product. Products are very much similar, but it's essential that the reinsurance program be established in 2019. The fear is that after seeing major escalations in premiums in 2017 and 18, without state intervention, we would see a similar escalation in 2019. This would be particularly disruptive in the off-the-exchange market, where individuals purchasing insurance are not somewhat insulated due to the availability of subsidies, but pay the full cost. It is now approaching for many families an insurance premium is now the same cost as a medium-sized house mortgage, and clearly premium escalations that we've seen in the past year can't be sustained if we want to preserve this market. What it is hoped for is that through the reinsurance program, we would be able to reduce premiums from what they otherwise might be by up to 30%. That certainly, other things being equal, would be a major reduction. But we also have to keep in mind that recently there have been some recent evidence that costs are growing overall in the entire healthcare economy. So although this would be some relief, we're certainly not solving all of the problems through a reinsurance program for this important market. So with that, I'll again say we will be sharing that information with commissioners. I'll leave it to the guidance of the chair whether the commission wishes to respond as an organization or as individuals from organizations you represent. This is a major and important initiative, very bipartisan, members from both sides of the aisle, as well as the governor got behind this, and it reflects the importance of stabilizing the market.
Thank you very much, Ben. I'll just make one comment about this. Section 1332 waivers under federal law can give the states significant flexibility to make changes. And I'll just mention that a similar initiative, while the markets are radically different, a similar initiative was launched in Alaska. Again, a radically different demographic and so on. But nevertheless, they were able to reduce the premiums by 25% in the individual market. And so the states do have a real role here using the waivers. So I think we'll talk about this further, but I think it's an excellent step in the right direction. Before we go any further, do any of the center directors have any additional updates at all? Any? Dr. Sharp, no? Okay. Yes, Randy?
Looking at the data release for the APTD that we've been working on, have we done an analysis of the Part 2 regulations for mental health substance abuse records for people from facilities that receive federal money? There's some ferment in the industry about that. I was wondering if that affected our operations at all.
We have not conducted any formal analysis on that. I know you mentioned that at a previous meeting, but it's something that Linda's group, along with our legal staff, will take a look at. We have not heard anything formally from any payer that I'm aware of regarding compliance.
Any further questions at all? Okay, no further questions. Ladies and gentlemen, one of the functions of the commission is to carry out public interest, and that means that we have to distinguish periodically between our role here, serving public interest, and any private interest we might have. And that's why we have ethics laws in the state of Maryland. Before considering any further actions today, I want to remind the commissioners that if they wish, if they choose, looking at a situation that comes before them, that they should recuse themselves on an agenda item, they should do so. And appearance is important. So what we are asking you to do, if you feel that you must recuse yourself, is that you leave the meeting and go to the conference room, and the staff will let you know as soon as the commission has completed action on that agenda. I just want everybody to be aware of that. It's a critical function to maintain the appearance of propriety at all times. The next item is a certificate of need for the Sacred Heart Home. The Sacred Heart Home applied for a certificate of need to build a replacement facility on its existing campus, which will reduce the number of comprehensive licensed beds in the facility. Kevin McDonald, the chief of the Certificate of Need Division, will present the staff recommendation. Kevin, thank you very much.
Thank you, Mr. Chairman. The facility that is up for replacement was built in 1926 and added on to in 1963. It is owned by the Sisters Servant of Mary Immaculate. That building is 58,000 square feet on 3 floors. Just one patient room has a private toilet, 4 have shared toilets, and the rest rely on a public toilet room, and all residents use communal bathing facilities. So clearly it does seem time for replacement. It will be a replacement, albeit on a smaller scale, on the same site. The building will be actually bigger than the current facility. It'll be about 60,000 square feet, and there will be all private rooms arranged in 4 pods of 11 rooms each, surrounding a central courtyard. Total project cost is $19.2 million. It will be funded with $8 million in cash, an interest-free loan from the order of $4 million, and a mortgage of $7.2 million. In looking at the project vis-a-vis our standards and criteria, the facility has an excellent quality record. It currently meets or exceeds the state average in nursing home performance on 8 of the 12 key quality measures, and ranks lower on 2. As of last week, it renewed itself as a 5-star facility, which it's been a 5-star facility for a significant period of time. Looking at need, there is a bed surplus in the jurisdiction, but the applicant is not going to be adding beds, and in fact, there will be a bed reduction that will reduce the current surplus in the jurisdiction by 58 beds. Sacred Heart Home has had a very healthy census. In the years between 2012 through 2016, it was just under 96%. The jurisdiction has an occupancy rate above 90%, which is a couple of points higher than the statewide average. There's likely to be very little impact on other facilities. In terms of viability and financial feasibility, the financial resources to support the project look to be available. The facility has operated consistently with a modestly positive bottom line, and projections show that is likely to continue. The staff finds that the proposed project is in compliance with the applicable criteria and standards, and recommends approval with the 2 standard conditions related to signing an MOU with Medicaid, agreeing to maintain and then subsequently maintaining at least the minimum proportion of Medicaid patient days required by the state health plan. With us today, representing the applicant, are Sister Vasha Kodziak, the administrator, Joe Welke, the general contractor, James Crisp, a CPA and the applicant's auditor, Paul Miller, who assisted with the application, as well as Andy Solberg, their CON consultant, and Jack Eller, their attorney.
Okay. Thank you very much, Kevin. Sister, welcome. We're very happy to have you, and with Mr. Weller and Mr. Chris and Solberg and Eller. Are there any questions at all from the commission on this? Yes. Commissioner?
Just a brief comment. First, great job in preparing, reviewing the application. I couldn't help but be struck by the fact that our current process requires people to submit a CON for the privilege of reducing the size of their nursing facility. I think we have to just keep that in mind as we go through the process of reconsidering the regulations going forward, in the context of what the statute allows, obviously. But that I can't help but look at this thing and think we just increased the cost of decreasing the size of the facility by having this process in place the way it is. So, but thank you very much for presenting it.
All right. Do I have a motion to approve? A motion, do I have a second? Any further discussion? All those in favor, say aye. None opposed? Sister, thank you very much. You have your certificate of need. Okay. Our next item is a certificate of need item, Anne Arundel Medical Center Mental Health Hospital. Commissioner Tamarchio served as the reviewer of this certificate of need application by Anne Arundel Medical Center. It was contested. The certificate of need application is to establish a 16-bed special hospital, psychiatric hospital, to be located adjacent to Anne Arundel Medical Center's substance abuse and treatment facility. The interested party in the review, the University of Maryland, Baltimore, Washington Medical Center, notified Commissioner Tamarchio on April 4th, 2018, that it would not be taking exception to her recommended decision. The reason is the inclusion in her recommendation of a condition that the psychiatric hospital cannot increase its bed capacity without obtaining the required approval from the commission. I would like to acknowledge representatives of the Anne Arundel Medical Center here today. Tori Bayless, who is the president and CEO. Paula Witterlight is the chief strategy officer. Dr. Malik Joshi, see you here? Yes, Dr. Yoshi, thank you. Dr. Ray Hoffman, the medical director, the Mental Health and Substance Abuse Division. Barbara Jacobs, the chief nursing officer. Marcia Hartig, who is counsel in this review. Okay, welcome all. Commissioner Tamarchio, I would like you to address the commission regarding your recommended decision.
Thank you very much, Commissioner.
All right, we have one point. Commissioner Pollack is recusing himself for this consideration. Okay.
Thank you very much. Colleagues, you've read my recommended decision and the cover memo in this review. For that reason, I'm not going to go into a lot of detail today. The 16-bed psychiatric hospital proposed by Anne Arundel Medical Center at a cost of approximately $25 million is a resource that I have found to be needed in Anne Arundel County. Anne Arundel Medical Center is the fourth largest hospital in Maryland by patient volume. Between 2011 and 2016, psychiatric discharges of Anne Arundel County residents increased by over 10%, and the average daily psychiatric census of county residents rose by almost 20%. The psychiatric referrals that Anne Arundel Medical Center's emergency department sent out of county could easily fill the beds in the proposed mental health hospital if it retains the expected percentage of psychiatric patients whose diagnosis it could treat. The psychiatric hospital that currently gets the greatest share of these patients is Sheppard Pratt Hospital in Towson. They submitted a letter of support for Anne Arundel Medical Center's application. As Commissioner Moffitt has noted, a representative from Sheppard Pratt is, well, take that back, they were defendants, sorry. I want to thank you. I want to thank the University of Maryland, Baltimore Washington Medical Center for deciding not to file exceptions for my recommended decision. They were never against the addition of psychiatric beds in Anne Arundel County, but they thought that the beds should be located within Anne Arundel Medical Center rather than 2 miles away on Riva Road, adjacent to the medical center's substance abuse treatment facility known as Pathways. I want to point out that I believe the placement of a psychiatric hospital on the Pathways site makes programmatic sense, both for the patients of Pathways as well as the patients of the medical health facility. Also, the Riva Road location, the mental health hospital will have room for its proposed partial hospitalization program with separate areas for adults and adolescent patients. It also plans to relocate outpatient mental health services to the campus when the leased space where they are currently providing the services expires in 2021. The basement level of this 4-level building will contain a secure ambulance bay to privately and safely receive patients. The building will contain shell space on the 3rd floor, and at the current time, Anne Arundel Medical Center plans to relocate its adult outpatient clinic when that current lease expires. The space is also planned for an after-school intensive outpatient mental health program that too is located in the lease space elsewhere. In addition, Anne Arundel Medical Center thinks the additional space in the facility could be used as an inpatient unit focused on adolescents. In summary, I believe Anne Arundel Medical Center's mental health hospital will improve access to psychiatric care for Anne Arundel County residents and is a needed project. The project meets all applicable requirements in the state health plan and it complies with the certificate of need review criteria. For this reason, I have outlined, I move that the commission adopt my recommended decision as the decision of the commission and award a certificate of need to the Anne Arundel Medical Center Incorporated to build a special hospital, a psychiatric hospital, to be known as the Anne Arundel Medical Center Mental Health Hospital, with the condition that it cannot increase its bed capacity without obtaining required approval from the commission. Thank you.
Motion has been made. Do I have a second for the motion? Candace Peters seconds the motion. Fellow commissioners, are there any questions for Commissioner Tamarchio? Any further discussion? Yes, Commissioner Thomas.
You know, we hear so much about stigma as it relates to mental health. And given an opportunity to start from the ground up, do you get a sense that it's not an issue with this particular facility?
My sense,
It's called Mental Health Hospital. Right. So I'm just wondering.
Just for the name of the facility, I think more so in this community, the name of Pathways is a recognized and esteemed name that has a long history within the community and has a sense of trust, not only for their patient care, but also to their access to the community. So taking the stigma of mental health away and making it into a disease that you live with and you treat going forward, I think is the path that they're attempting to do by relocating the services to the Pathways site.
Thank you.
Are there any further questions? Any further questions at all? We have a motion. We have a second. No, any further discussion? Okay, the vote then is on approval of the reviewer's recommended decision and awarding a certificate of need to Anne Arundel Medical Center to establish a special psychiatric hospital. All those in favor say aye.
Aye.
Any opposed? The ayes have it. Okay, ladies and gentlemen, you have your certificate of need.
Commissioner Mosman, can I have a
Yes.
moment? I really want to thank Sue Ellen and Kevin for their hard work on this. It was a tedious process, and we wanted to make sure every step of the way that we approached the issue with great care and respect, not just for the people who live in Anne Arundel County, but for all of the people who are going to be able to use this facility and for the difference it's going to make in their lives. So thank you very much.
I want to thank you, Commissioner Tamarchio, for taking it on. Being a reviewer is not always an easy task, and it is a service to the people of Maryland. So thank you very much for taking this on. Ladies and gentlemen of Anne Arundel County, congratulations again. You have a certificate of need, and you serve a great hospital. So thank you very much. Okay, fellow commissioners, the next item before you is a proposed set of regulations for the state health plan for facilities and services in the area of cardiac surgery and percutaneous coronary intervention services. At the March meeting, Eileen Fleck, who is the Chief of Acute Care Policy and Planning, reviewed proposed changes to the state health plan for cardiac services. And she described how the changes had been developed in consultation with the Cardiac Services Advisory Committee. The commissioners, if you all recall, engaged rather heavily in this issue and suggested several changes. Ms. Fleck will present COMAR 10-2417, State Health Plan for Facilities and Services, the Cardiac Surgery and Percutaneous Coronary Intervention Services rules as proposed permanent regulations. Eileen, thank you very much, and thank you again for your very hard work in this area.
Thank you. Good afternoon, Mr. Chair and Commissioners. So before I discuss the key changes to the State Health Plan chapter for cardiac surgery and PCI services, I wanted to address a couple issues that have been raised at the March Commission meeting. Dr. O'Connor and Dr. Pollack requested confirmation on whether a program could perform only percutaneous procedures, such as percutaneous valve procedures, and still meet the volume standard for cardiac surgery programs. It would not be possible for a program to meet the volume requirements in the chapter through performing only percutaneous procedures. Almost all of the percutaneous procedures are not defined as cardiac surgery. Dr. O'Grady had also asked about revising policy number 1, which states that cardiac surgery and PCI services will be provided in the most cost-effective manner possible, consistent with safely and effectively meeting the healthcare needs of appropriate patients. Dr. O'Grady proposed referring to cost-efficient care rather than cost-effective care, if it would still meet the needs of the Commission. Staff considered this change and concluded that because the general standards for all certificate of need reviews included in the procedural regulations refer to cost effectiveness, the terminology in COMAR 10-2417 should be consistent with the procedural regulations. So there are several changes in the draft regulations that I'm going to review. These changes are covered in the memo that I sent to you. Although staff did not receive any comments on the draft regulations posted for informal comment, some changes have been made in response to feedback from the commissioners at the March meeting, as well as verbal feedback from our Cardiac Services Advisory Committee members. The definition of cardiac surgery has been revised based in part on a re-evaluation of the ICD-9 procedure codes that are used in the identification of cardiac surgery cases. Although some ICD-9 procedure codes are no longer defined as cardiac surgery, these procedures did not contribute to the volume count for cardiac surgery programs because the procedures are not defined as open heart surgery in the current chapter. In addition, some of the ICD-10 codes that correspond to these procedures are defined as cardiac surgery in the draft regulations. There are several ICD-9 codes that have been added for use in the identification of cardiac surgery cases, with some or all of the corresponding ICD-10 codes also used to identify cardiac surgery cases and to count for volume at cardiac surgery programs. Overall, the proposed changes are expected to have a small effect on the volume counts for cardiac surgery programs. An appendix lists which procedures are used in the identification of cardiac surgery cases, and a definition of case has been added in Regulation .11. In conjunction with changes to the procedure codes used to identify cardiac surgery cases, the definition of open heart surgery has been removed, and references to open heart surgery and the standards used to evaluate certificates of ongoing performance and certificate of need applications have been replaced with references to cardiac surgery because the term cardiac surgery is more accurate. With regard to patient outcome metrics for certificates of ongoing performance for primary and elective PCI services, staff has suggested revisions to the current standards, which reference all-cause 30-day risk-adjusted mortality rates for elective PCI cases and primary PCI cases. Staff recommends that the standards for both primary and elective PCI programs be revised to refer to in-hospital mortality rates rather than the 30-day all-cause mortality rates, and we are recommending that the national average rather than the statewide average be used as the primary benchmark. But the statewide average would be used as a second benchmark if it's timely available, if it's obtained in a timely manner. Currently, only the proposed primary benchmark, which references the national average, may be used as a benchmark. These changes are needed in order to be able to use timely data to avoid further delays in reviewing hospitals' applications for certificates of ongoing performance, and it provides flexibility in the standards that are used. Another change to the regulations that pertain to PCI programs is a change in the data collection requirements. The current regulations reference the Action Get With the Guidelines Registry, which was jointly operated by the American College of Cardiology and the American Heart Association. In April 2017, these organizations announced the immediate dissolution of their partnership on the Action Get With the Guidelines Registry and developed separate registries. The proposed regulations delete references to that registry and do not require hospitals to participate in the resulting separate data registries. Maryland hospitals will continue to participate in data collection through the MCDR CAS-BCI registry, which is what we have traditionally primarily relied upon for our work. Staff is proposing changes to one certificate of need standard, the financial feasibility standard. In the current chapter, the standard provides that within 3 years or less of initiating a new or relocated cardiac surgery program, the program will generate excess revenues over total expenses for cardiac surgery if utilization forecasts are achieved for cardiac surgery services. This language has been removed and replaced with language that requires an applicant to demonstrate that the proposed cardiac surgery program will be financially feasible and will not jeopardize the financial viability of the hospital. This change is needed because the current policy is adopted by the Health Services Cost Review Commission regarding the handling of market shifts and adjustments to global budget revenue as a result of these shifts are not compatible with the requirement for short-term standalone profitability for a new cardiac surgery program. The last change that I want to mention is that the standard for institutional resources, which is one of the standards used to evaluate certificates of ongoing performance for primary PCI services, has been revised to clarify the requirements, including reporting on lapses and service availability. Hospitals are required to have primary PCI services available 24 hours a day and 7 days a week, but sometimes compliance with the standard may not be feasible, and the revised standard acknowledges this possibility. The draft chapter also includes language that explains when and how a hospital may be granted a temporary waiver from this standard. The revised standard also provides that hospitals are required to record lapses in service availability, and upon request of commission staff must provide this documentation. That concludes my presentation, and I'd be happy to answer any questions. I would also like to ask that the commission consider adoption of proposed regulations for cardiac surgery and PCI services, COMAR 1024-17.
Thank you very much, Ms. Fleck. Fellow commissioners, are there any questions for Eileen? Any? Commissioner O'Grady, anything?
No, I was just, and thank you for taking into consideration the national versus state on the risk adjustment.
Thank you.
Mr. Pollack?
I agree. I'm happy with the way you've incorporated our comments from before. Thank you.
You're welcome.
Commissioner O'Connor?
I just still have a concern about why PCI is not considered cardiac surgery when the endpoint of bypassing an area of plaque in the coronary artery, which the cardiac surgeon decides to do it as a bypass or in discussion with the cardiologist as an intervention to put a stent in. The endpoint's the same. To me, it's like deciding, am I going to do this gallbladder open or laparoscopically? The endpoint's the same. Taking the gallbladder out, they're both considered surgery. So I just have a basic, I don't know if you want to call it objection to how they separate out PCI from cardiac surgery. But I'm not going to argue with this committee that apparently has come to that conclusion. So.
Okay, we're regulating both. They're just different standards for each program.
Okay. All right. Thank you very much, Dr. O'Connor. Any further questions? Okay, we have a request to approve as proposed regulations the staff cardiac surgery and percutaneous coronary intervention addition to the state health plan. Do I have a motion to approve the regulations? O'Grady and Dr. Pollack. Okay, second. Are there any further? Okay, are they further discussion? Okay, all those in favor say aye. Aye. Any opposed? Thank you very much. Thank you very much, Eileen. This was a great deal of hard work on your part. And before moving to the next item, I just want to take the opportunity because you have been working very, very closely with members of the medical profession, and I want to take the opportunity to thank the Cardiac Services Advisory Committee members who've worked with you on this, specifically the co-chairs of the committee, Dr. Ron Salinger and Dr. Stafford Warren, for their terrific work in this area, working with you and the commission over the past years. I think it's a terrific partnership we've developed, and I think we've gotten a very good product out of it.
I'll be sure to pass that along to them at our next meeting.
Please do so. Eileen will present COMAR 102409, the State Health Plan for Facilities and Services, the Acute Inpatient Rehabilitation Services proposal as final regulations.
Thank you.
Eileen?
So as explained in November of 2017, when the Commission adopted the regulations both as proposed and emergency regulations, the State Health Plan chapter for acute inpatient rehabilitation services needs to be amended due to recent changes in the data sets that are used to implement the bed need forecasting methodology. The amendments adopted by the Commission pertain only to updating the bed need forecasting methodology, so it's a very narrow change. Staff requested approval of emergency regulations because in the fall of 2017, the Commission received a letter of intent proposing the establishment of an acute rehabilitation hospital, and an updated bed need forecast was needed for that review. The emergency regulations were approved by the Joint Committee on Administrative, Executive, and Legislative Review in March, and they're currently in effect. However, the emergency regulations are only effective until June 22nd of 2018, so we'd like to move forward with adoption of final regulations. In response to a notice published in the Maryland Register on February 16, 2018, announcing the start of a formal 30-day public comment period for the proposed regulations, we did not receive any comments. We'd also post the notes on our website and on Twitter. So although typically comments are submitted by stakeholders on proposed regulations, the changes are limited in scope, and so we're not necessarily surprised that few people are concerned about the changes that we're making. So at this time, staff would like to ask the Commission to adopt final regulations for COMAR 102409, and I'd be happy to answer any questions.
Okay, very, very good. Fellow Commissioners, do we have any questions for Eileen on this? Any questions at all? No questions. Okay, may I have a motion then to approve? Yes, a motion, and seconded by Commissioner Fly. All those in favor say aye. Aye. The ayes have it. Thank you very, very much, Eileen. This was again an excellent job.
Thank you.
You don't have any more regulations handy, do you? You're finished.
For today.
Yes, you can go home. Thank you. All right. Okay. Our next item has to do with legislation. Reporting from the front in Annapolis. The 2018 legislative session concluded on April 9th, and Megan Renfrew, our new chief of the Government Relations and Special Projects, will present the final status report. Megan, we are profoundly happy to see you.
Good. Thank you. So as you said, the legislative session ended on the 9th, so it's about 2 weeks out at this point. We have about 3 more signing sessions that the governor has scheduled. So while this says final in the agenda, it's not entirely final, and yet we expect nothing to change between now and the end of May for the topics that I'm going to talk about today. And I'm going to talk today about the budget, but a little bit, and then laws that have passed that we have an interest in, and finally, just a quick reminder of some things that failed that we had an interest in, and just so we don't lose track of those topics, and then an overview of the responsibilities we have as a commission moving forward, resulting from the legislative session. Part of the
Where's the clicker?
The up and down arrow. Okay. So I'm learning things every day. There we are. So for the appropriation, MHCC ended up with 54.8 million appropriation for fiscal year 19. This is a slight decrease from fiscal year 18. Our operating budget is 14.5 million, also a slight decrease from last year. This largely has to do with 4 pins that we gave to, hopefully temporarily, to the Department for Mental Health purposes. And then, and there was also in the BRFA a transfer from the trauma fund, which had a fairly large balance to help fund Medicaid providers. And that was a one-time transfer. Any questions on that?
Yes.
Yeah.
What is ICN
Yes.
and MNSOPA?
Yes. ICN is the Integrated Care Network. We act essentially as a bursar to provide funding for HSCRC and CRISP IT initiatives. So that's what that fund is for. And then the other one, MNSOP, is a pass-through to the University of Maryland for shock trauma.
So are those negative numbers? The minus, they're down 25 million from last
year? No, those are dashes.
Oh, okay.
That is confusing. I can see that. Yep. No. Okay. So moving on, we do have 2 bills that we've been tracking that have been signed into law at this point. One of them is the reinsurance bill that Ben already spoke about at a fair amount of length today, so I'm not going to go into that. The second is a study on infant mortality rates for African American infants and infants in rural areas, which will be, I'll talk about it a little bit more when we get to our to-do list at the end of the presentation. And in addition, we have a fair number of bills that we expect will be become law in the next 2 months, either signed or just by sitting on the table. So that includes a study of electronic systems for providers to access patient prescription drug information, a long-awaited change to the statutory definition of HIE that David's group has been working on for quite some time, a bill that allows interstate licensing of physicians through a compact. This doesn't impact us directly, except that it may impact some of our workforce data down the line, depending on the uptake in that program. We also had a bill that modified CON requirements for ambulatory surgical centers and similar facilities that were owned by HMOs. And then we have a study of reimbursement and coverage issues for EMS, particularly if EMS were to treat and release patients or transport them to non-hospital locations. Then we have a bill that establishes an advisory committee on health records and payment integration programs that will make recommendations about whether or not such a program should be established in Maryland. And then finally on this list, a bill that establishes a rural health collaborative pilot program in the Mid-Shore region. And again, this last one is one we don't have much role in moving forward, but it was a result of our participation in the rural health work group, so it comes out of our work. In addition to those bills, there are 3 mandate bills that passed in this session that we played a role in either studying the issue or provided comments, and that includes health insurance mandates for coverage of elevated blood glucose levels and prediabetes, coverage for lymphedema treatment, and coverage for fertility preservation largely for individuals undergoing cancer treatment. There were a few bills that failed that we have been keeping track of. The most important was the bill related to repealing the CON requirement related to certain substance use facilities. And so that's something where we hope that we can continue to build support for that issue moving forward and bring it forward in another session. And then a number of other bills of interest that failed that we either had worked on or otherwise had some interest in.
Any questions on that? So this gets us to the work moving forward, which I think is the important part. So we have 6 studies or work groups to be pulling together based on legislative outcomes or letters from our legislators. We have a couple of letters that we received. So David Sharp's division will be taking a lead on the study related to the prescription data system, the health record integration system, and a request we had to study school-based telehealth. I will be working to lead MHCC's efforts on the study related to infant mortality rates, the EMS provider coverage and payment work, and a study related to maintenance of certification requirements for hospital privileges and insurer participation that the physicians had asked for or were advocating for. And it is also likely that we will be asked, but haven't yet received the request, to do some study of insurance mandate bills that failed in the last session to better understand their impact should they come up again in the future. So I will keep you all updated as things change and as those work groups move forward. I welcome ideas, suggestions for participants for those work groups as we form them, or any other insights that you want to offer me on this work. And do you have any questions? That's the end of my presentation.
Thank you very, very much, Megan. Fellow commissioners, do you have any questions for Megan? Commissioner O'Grady.
Just one, and I don't know that you can answer it. It may go over to David or whatever. But I thought that under Medicare, we already had a fair amount of electronic prescribing, et cetera, and the feds had sort of paid the bill and implemented that one. Is this something very different for non-Medicare patients, or am I just wrong?
I would have
I often am, right?
I think I'd have to defer to David on that.
So just so we can move along.
Yeah.
I can
I'll-
ask this later. I didn't mean to cause.
So this envisions using a authority the state has through the prescription drug monitoring program. Dispensers submit information passing through QUIS to a state repository. It's been recognized by many that the dispensers, when they submit to the state, have the capability to submit not only the controlled data that is the target of the prescription drug monitoring program, but other non-controlled substance scripts. That information available in a centralized location available through QUIS is thought to provide some of the crumbs for not only what's happening with broader issues of care delivery, but also for medication reconciliation. And while you're right that the federal government did provide for some significant subsidies, $30 billion or so is what I recollect, it's still far from seamless in terms of the sharing of information regarding pharmacy information with practices. I think we see this bill did not move for a number of concerns voiced by physician organizations. There's some issues related to cost, but there are several strong advocates in the legislature that thought further study is warranted. One of those, Delegate Morheim, is leaving the legislature, so it remains to be seen. I think we want to look at the evidence, the practicality of this going forward, but are keeping the verdict open until we gather more information.
Okay. Any further questions? Further questions, observations, anything?
So just, I see Bridget Zumbro did leave. One little point here on we mentioned the PINs, the personal identification numbers, that last fall the commission released, or the department appropriated, depending on how you look at it, some vacant PINs that we had. Recall that from 2015 through 2017, due to the fact that our expenditure cap had not been raised since 2008. Although we had pins, the ability to hire our budget did not allow us to fill those slots as rapidly as we did. The department facing a number of court issues regarding staffing of the state hospitals, behavioral health facilities, largely made a sweep of all organizations that had vacant pins, and as I think Megan correctly stated, the department borrowed them. Our position is that we would always step up to help if we could. Our expectation is that those pins, especially because they are deployed in our CON activities, we've had a number of significant retirements over the last year as well, and if anyone looks at our docket, our CON docket, their jaws would drop, that we will make a very fervent effort to retrieve all 4 of those pins. If they are not available because of the crisis in behavioral health, we would move in the next legislative session to obtain any that cannot be released to us by the department, because there's a staggering backlog on CON requests. Dr. Pollack reminded me that speed is also money from the standpoint of organizations, that we simply can't do this if we don't have staff, trained, skilled staff to do this work. And although we are streamlining, what my observation is that the new waiver has not brought absolute collaboration among health systems, but actually has promoted some additional competition. We are dealing with a fixed pie, after all, that we should expect, as long as there's a CON process, that many projects that heretofore had been not opposed by other parties will now be opposed because of the concern on global budgets. So a bit of clarification on that. I think it's important that we have appropriate staffing levels for the volume of work that is assigned to us.
Thank you very much, Ben. Okay, thank you very, very much, Megan, on your maiden performance before the commission. The next presentation has to do with spending and use among Maryland's privately fully insured residents. Ken Yates Trotman, the chief of the Cost and Quality Analysis Division, is going to present highlights of the report on spending and utilization patterns for Maryland residents. These are residents that are insured through both through the individual market, the small employer market, and the large employer market. The analysis that Ken is going to present to us relies on data from 2014, 2015, and 2016. This is data from the Maryland Medical Care Database. It contains both claims and encounter data, which is submitted to the commission by it's most private insurance, not all private insurance. Is that correct?
Only private insurance.
Okay. Well, thank you very, very much, Ken. The show is yours.
Thank you, Chair Commissioner. As stated in the Maryland statute, the Maryland Healthcare Commission is required to report annually on healthcare spending and utilization. The data source for this report is the Medical Care Database, which includes claims and enrollment information submitted by private health insurance companies, HMOs, TPAs, and PBMs for 2014 through 2016. The population used in this report is Maryland residents who are under age 65 and are enrolled in fully insured private health insurance plans. This report examines variations in spending by market segment, demographics including geography and age, and by service category. Today's presentation is focused on all markets as opposed to the individual market, which was presented at the February Commission meeting. for takeaway. The overall takeaway is that there is a deceleration in PNPM spending growth across all market segments from 2015 to 2016. For example, total PNPM spending for all markets combined increased by about 5% in 2016 compared to about 12% a year ago. This deceleration in spending was observed in each market, in which the individual market showed the largest slowdown in spending growth from 2015 to 2016. Also, the individual market continues to have the highest PNPM spending across markets in 2016. Oh, you could have questions if you want.
Here, just one on this one with the individual market. Are we thinking that the individual market is running higher because of the underlying population being insured, or is there something else about trying to organize in an individual market that makes it somewhat less efficient that as the group gets larger?
Well, it's the underlying population. We have a lot of sick people that have transitioned from our high-risk pool, and also the uninsured have actually transitioned into the individual market starting in 2014, but the full effect was in 2015.
So if we risk adjusted this, it would probably go away. Thank you.
Changes in PNPM spending for all markets combined varied by service category in 2016. For example, looking at the hospital services, hospital outpatient facility had a moderate increase in spending, which was driven by utilization. However, the overall spending for this service category was reduced by a decrease in unit cost. A decline in unit cost caused a small decrease in hospital facility spending. Looking at the non-hospital services, no increase in PNPM for non-hospital outpatient facility was driven by an increase in utilization, which was offset by a decrease in unit cost. Both utilization and unit cost caused a small increase in spending for professional services, and unit cost solely drove the modest decrease in labs and imaging spending. Looking at drug expenses, physician supply drugs had a large increase in spending that was due to unit cost, and PNPM spending increased moderately was driven by both utilization and cost for prescription drugs. Illness levels for members across all markets segments deteriorated from 2014 to 2016 as expenditure risk scores increased across all markets each year from 2014 to 2016. We will see this on the following slides.
One question about when you're looking at the cost, are these the total cost of the claim or the part of the claim paid by the payer?
This is total cost.
If everybody was buying a gold plan one year and they all moved down to bronze, your analysis would still be based on the total cost.
Yeah.
It wouldn't look like a cost reduction.
No, not at all.
So it is cost reduction in terms of the claims. They save money as well.
Healthcare in general.
Yeah. The underlying trend probably isn't. Can I ask one question too while we're interrupting? So you also said that physician-administered drugs were up. Now, did you find any patterns in the data that would indicate, is that sort of oncology-driven, or is that across the board? Is there anything that would indicate why, when we think of total drugs versus physician-administered, we're getting into a sort of a certain specialties and certain things that are driving it. So I just didn't know whether this is an overall trend, or are there particular areas that we know, well, like Hep C. There was a blockbuster in Hep C, but a very expensive one.
Right. We did not look. This will require a slightly deeper view on the physician supply drug.
Okay.
But I'd say the cancer drugs. Are mostly
well, in next year's report, maybe if you have a sec, you see a pattern like this.
Absolutely.
Love to see a little deeper.
Sure.
Thanks.
Ken, following up on that point, when you're talking about drugs, you're including the biologics in that category as well, right?
Yes.
Okay. So the biologics recently have gotten very expensive.
Yes.
And it's not the same as the traditional, pharmaceutical type.
Mm-hmm.
Right. Okay. Just important point.
Okay. As noted on the previous slide, illness levels for members across all markets have deteriorated as expenditure risk scores for each market have increased every year from 2014 to 2016, with the individual market showing the largest increases from one year to the next.
This is a question about that. I'm not sure I understand why that's occurring. Do you have any thoughts? I mean, I understand that there's adverse selection in the individual market, but I don't know why that adverse selection is worsening between 14 and 16.
Okay. Well, in 2014, there was a delayed entry of the sicker population into the individual market. So our high-risk pool, which is the MHIP, actually ended at the end of 2014. So 2015, you see the full effect of that population. So therefore, you have a higher risk score there.
Mr. Director, I'm sorry. Go.
So, as most people recall, the exchange got off to a somewhat stumbling start in 2014. So not only was the MHIP population, about half of it remained in MHIP through 2015. Some migrated to the exchange well after the first of the year. So you're likely seeing a whole set of effects, smaller overall enrollment in the individual market, a healthier population in the individual market in 14, that then really, I think 2015, you had full participation of the MHIP population, largely going with Care First, who was the historic TPA for the MHIP market, and most of that going into, at least based on our evidence and confirmation from Care First, largely PPO and less managed plans administered by Care First.
Speaking of Care First, Randy, you had a question.
I think that's right. There was some delayed implementation for 14 to 15, but then also as it continues to grow up, I'm not sure that it's the individual people. I mean, an individual person who's already sick is likely to get sicker, but it's going to get sicker on average as healthier people drop out of the bottom.
That is true. That is true. It will show more effect.
And the average market goes up, which is what the legislation in Maryland is attempting to address. Right.
I'm a little more surprised by the large employer, and the small employer followed up. Now, do we, I mean, because it's unidirectional, I'm assuming that this is significant. Should we make any, how much should we worry about a 0.28 to a 0.32 on large employers? Is this an aging of the large employer workforce? Is this any idea what would drive this? Is this that employers are not offering new entry workers quite as generous a benefit? I think it's, or they're not offering them health insurance at all. They're saying go to the exchange.
We might want to ask what the effect on the absence of self-insured data has.
That's true.
As well, because if you don't have private insurance plans, there's going to be a balance that any large employer can look at how sick their population is. Does it make sense to buy an insured product or self-insured product?
Yes.
And then
My own pool or go into the bigger.
So if we don't have the full range of data, there also might be some problem with people.
And when did that affect? Is that during this time period that the self-insured would have been out of the data?
It would be. It started in 2015. We had all of the self-insured data, but this was not. We never have included self-insured data into this report at all. So.
Oh, okay. So that's controlled for.
Yeah.
Any idea what else might be going on that both large employer and small employer seem to be getting a sicker population than they did just a couple of years earlier?
Well, it's a combination of aging population. Well, and as people get older, they have probably more.
But we would hope that the Maryland employers are hiring new people all the time to keep their average age roughly constant. The one thing I would suggest that we hit in Medicare is as your risk adjustment methodologies get better, you're just picking up. So it's not like anybody's sicker. They were always that sick. You're just better at capturing you know, kind of your well-controlled diabetic versus your not very well-controlled diabetic, and working that through. Do we have anything like in that kind of a method up? Because this is just sort of gross. Nobody's trying to risk adjust this, are they?
No,
This is just your flat.
this is
You
just
know,
a
you
flat
spent $5,000 per person last year. You spent $5,500 this. Okay.
All right. That's a very interesting point, because you're right. These were the first 3 years of risk adjustment as well.
But they're using raw kind of nominal dollars spent. Is there a discounting for just general prices?
No, this is
Okay. Okay, so if we see a 1 or 2% increase, you know, certainly healthcare spending, prices of healthcare spending has gone up, those kinds of ranges. Okay.
Director?
So, you know, one of the things that we've seen from other data comparisons from other states, and I don't know if there's also a time series impact on this, is that this is based on ACGs, and what we've seen is that Maryland typically reports more, Maryland providers and payers capture more diagnosis codes, and that's in comparison to other states. We're still trying to understand whether actually the underlying illness burden is higher in Maryland because there are more diagnosis codes reported, but
Or
we don't,
financial incentives.
but we also, you know, it could be that the incentives to report more diagnosis is increasing over time, and what we're seeing is sort of the baseline effect in large employer and small employer markets, but really amplified by people are really.
Could I ask for next time to see this kind of put it in constant dollars, just so we get that feeling in healthcare spending, not general prices in the economy.
Right.
Just sort of so we get that feeling. Are these people actually getting sicker or not? Is there something you've changed the way you measure? Any of those other things so we can control for? Because some of that I guess I wouldn't be surprised if the way it goes.
Well, there's another underlying fact, and that is that in the general, within the general population, we have seen, especially in the last 15, 20, 30 years or so, we've seen a tremendous increase in chronic illness.
Right.
And you know, I mean, and we're talking about the bad one is diabetes. I looked at some of the new data coming in with regard to new enrollees in Medicare, and the good news is that something like 50 or 60% fewer people who smoke are turning 65 and enrolling in Medicare. But good Lord, the increase in the number of people who are 65 who have diabetes has gone up dramatically. And so, you know, the bad news about all this for all of us is that this image that was popular about 10 or 15 years ago of the super healthy baby boomers at the age of 70 jogging down the beach. Well, Commissioner Thomas, you're going to be an exception.
Yeah, that's right.
Which proves the rule.
We'll be holding your beer for you when we get to the end.
Right. But anyway, none of that's true. I mean, so we're going to have, I mean, I know that there are really serious, we all know, I mean, there are serious problems within the individual market. And, you know, it's not a robust market. It's looking more and more like a very heavily subsidized federal risk pool is what it's looking like. But here's the point. I don't think any of us should be surprised, you know, that, you know, the downturn in healthcare cost growth is over. We're looking at the next 10 years for certain. Actually, right now it's starting. You're starting to see some very, very heavy increases in healthcare costs. Commissioner O'Connor.
Yeah, just don't forget Alzheimer's disease is on the rise, and that's a 24/7 care. It probably could be more expensive than diabetes.
Well, with the diabetes, though, that's up to 25% of Medicare population with type 2.
Right.
And so, you know, it's the relative cost. So you're now up into the 30s, so maybe even pushing 40% of total spending.
Yeah.
In some way, I mean, they got a ton of other things wrong with them. I don't have to tell you guys, but it's just it is a dominant trend that with the aging of the baby boom is only getting accelerated.
Yeah.
Which is, I think, probably what we're seeing. We may also be seeing here, to a certain degree, the holding of older workers in the labor force longer.
Yeah.
That would give you some of this sort of stuff, too.
Yeah, that's happening. Actually, thank God. It's going to be. I'm very serious. It'll help the trust funds.
Yeah, sure. not Medicare, because they'll collect their Medicare at 65. They won't put that off, but they'll put their Social Security on. Like they, they're smart, they won't put off.
Anything else? Go ahead, Ken. Sorry.
Looking at spending across all markets combined, with the exhibit on the left, we see that PNM spending has increased each year from 2013 to 2016. For spending by service category, the exhibit on the right, we see that the bulk of the PNM spending was dominated by prescription drugs and professional services at 26% of the total PNM spending. Outpatient hospital and inpatient hospital facility at 19 and 16% of total PNM spending respectively. Looking at changes in PNM spending by market and service category, you see here that the individual market has dominated most of the increases in PNM spending. Also, spending across all markets combined increased for all services, all service categories, except inpatient hospital, labs and imaging, where the PNM spending decreased by 2% and 3% respectively in orange bar. Based on the previous slide, we examine here some of the drivers of changes in PNM spending for all.
I'm sorry, Ken. Can we just go back for a sec? Because your previous slide showed lab and imaging just going through the floor. Any idea what's going on there? Is that as we make this shift from, well, is it we're doing more labs in the outpatient facilities? Or any idea why that would, or did we used to have a questionable overutilization of, I know there were questions about imaging in the past, but I thought that had been pretty much cut to the bone. Just any idea why this would be, everything else is going up, but that's going down? I think we know why inpatient hospital is going down because you see the shift to outpatient. But what's going on with labs and imaging? Any idea?
Well, the study, we did not, we are still trying to investigate the decrease in lab and imaging, but a study in Massachusetts saw that there was the utilization from 2009 to 2013 was flat, but however, there was an uptick in special imaging there was an uptick in special imaging, which does not reflect the decrease here, but we have to actually look more into the decrease here in the labs and imaging.
Okay. But there's no like technological breakthrough that suddenly the cost of MRIs
Well, inpatient volumes are dropping, and there's a drive towards completing your workup as an outpatient, including imaging. So the shift is, like you observed, is towards outpatient.
And do you think if you're operating inpatient versus outpatient, just because of the ease of ordering more, because just send him downstairs and get another MRI, that is there something about the practice pattern that would go on once you move from an inpatient to an outpatient that might just sort of cut the number of labs and imaging that would be ordered for the same patient?
Well, there has been a paradigm shift in utilization of imaging. Hospitalists across the board have been told to be a little bit more discerning about it. And everyone used to get a chest X-ray on admission. Now it's apropos to their presenting symptomatology.
One other thing I should add, this could be a shift in mix of services, looking at intensity. So the price for the lab and imaging might remain the same, but the type of the intensity of the service, maybe there might be more providers using less expensive technology to do the same service.
Right.
For instance, you have less use of MRIs instead of
what we saw from the Fed was on Medicare was you did see that sort of when PET came out and it was so expensive, it was sort of, this sort of, if X-ray doesn't work, you can go MRI. If MRI doesn't go, you can go CAT. Right. If CAT doesn't work, you can go PET. So nobody was told no, but it meant that the number of, the target population for PET went from, 100,000 to 20,000 because of, you had to go through the steps.
Director?
So, yeah, I mean, it's probably one thing we ought to, we'll think about is really breaking out lab from imaging. The thing they have in common is they're largely diagnostic procedures. But remember from when we did the studies on self-referral a couple of years ago, in the midst of that, we did get sort of a response particularly from orthopedists, that the fee levels in Maryland paid by private payers had fallen so dramatically that their interest in owning these devices had evaporated. So I think there is some deterioration in fee levels that's driving this. I also think we should, probably look at some of the specialty launched initiatives like launched by ABIM on Choosing Wisely, where a lot of people poke fun at those efforts because they point out that some of the things that physicians that are Choose Wisely on are actually seldom used anymore. But I think there's growing awareness, and I'd point to cardiology in particular about appropriateness that sweeping specialties that may be, as Dr. O'Connor pointed out, somewhat dampening down demand. But I think if you want to look at this, you probably want to break out imaging and lab separately, and probably look at maybe even diagnostic therapeutic imaging still further to see where the growth is going.
And we can look at to see how the intensity is behaving in the mix of services, whether providers are using less expensive technology to do the same service from one year to the next.
Okay. Yes, fine. Dr. Peters.
I would also think that the use of the electronic medical records that you have access, you're going to drive down those receipts, imaging and lab. So.
Right, you don't need to order another one, it's right in front of you.
So whether or not the provider has it, the patient may also have a patient portal, they can bring it to their visit. So.
Right. Can I ask our commissioners from the insurance industry, on these kind of services, would they be tied to a Medicare payment? Because we know that on things like labs, Medicare had moved to a competitive bidding system. Some of these other things in the past, or would it be Medicare plus 10, or would it just be totally, local area adjusted utilization measures? Okay.
It's not like a set rule.
Okay, or even a set trend within the industry that would say, we're going to just, if you're doing it for Medicare for $100, we're not paying more than 110.
When you go to negotiation, both the lab and the carrier know what Medicare's paying. So
got it.
You can't say it's irrelevant, but it's not like a rule.
Right, it's not a formula based.
Commissioner Pollack.
One thing that the payers are doing differently, have been since about that time, is decreasing the degree to which they'll authorize the use of hospital-based services for lab services that can be performed on an outpatient basis. And that, to me, looks like what that 3% represents. So it's typically about 3 times as much to do something like an MRI in a hospital-based facility as it is on an outpatient facility. So.
Speak up, Commissioner Flick, please.
Capitated contracts where labs just getting a PMPM for an individual. There are all kinds of contracts.
Okay. Can I ask a question about the small group market? If you look at the first 5 rows, it seems to be behaving strangely. There's no change in inpatients. There's no change in outpatients. There's a 13% increase in cost for outpatient non-hospital. Is there a reason why the data would be so different for that market than it would for the other 2 that you know of?
Well, I think the small group market is a pretty stable market. All of even the PMPM increases that we see has been really small compared to the individual market or even the small group. So there's a really stable market in the small group. I could really actually say that.
There's a greater demographic profile that is more stable in
Right.
small root markets. Is that
Yeah,
correct?
I see that.
But there's nothing going on in the data that you were like different data for the system.
No, I don't think so at all.
Okay. Any further questions? Ken, continue.
So based on the previous slide, we examined here some of the drivers of the changes in PMPM spending across all markets combined. The 9% increase in PMPM spending for outpatient facility was mostly a result of the large increase in utilization offset by a decline in unit cost. For outpatient non-hospital facilities, there was no change in PMPM spending due to offsetting increase and decrease in utilization and unit cost respectively. Prescription drugs spending have increased significantly and was mainly driven by unit cost. The 9% increase in prescription drugs was the result of both utilization and unit cost. Looking at shares of total spending by market for member out-of-pocket and insurer reimbursement, you see here that the large employer market has the lowest member out-of-pocket share in spending at 16%, while the individual market has the highest at 26%. Also, the PMPM spending in the individual market continues to have the highest spending at $460 across markets. That's my presentation.
Well, you're asking for more questions. I really honestly think that you really don't need any. I think you answered enough questions. I'll give everybody a chance to make one more shot. Does anybody have one question? Yes,
Just one
I
question,
knew it.
and it's very basic.
Very basic.
And I might sound ignorant asking this, but unit cost, is that just the arbitrary number that insurance companies will pay?
No. Unit cost is you take your claims and your allowed amount divided by the amount of utilization counts that you have. So for example, if you're looking at say like inpatient hospital, a unit cost would be like what's the cost per day?
I wanted to say thank you.
Oh, yeah. You can say thank you.
I think this is really interesting. It could be 4 times longer, and I'd be happy with it. Like not a level of detail. You can tell a lot of things about what's going on. Just looking at the last page, one suggestion when you're looking at the out-of-pocket reimbursed shares, it would be interesting to look at that over time in the market. You can tell whether it's getting so expensive that employers are having to buy down and get less expensive over time.
Yeah, this is pretty generous. I mean, being in the 80%.
So but in any event, it's really interesting. I encourage you to sort of think about like new ways to put things in here. You can draw emphasis about what's going on in healthcare.
Can I ask one short question?
Yeah.
One
short question.
Well, based on what you explained to Dr. O'Connor, so when we talk about unit cost, so the utilization, that's pretty straightforward. You know, I had 3 lab tests, you had 5, et cetera, et cetera. But on the unit, are we seeing discounts, rebates, those sorts of things? Are we getting down to what was actually paid to either the PM or the hospital or whatever, or are we still see sort of kind of, you know, initial claim sort of stuff?
When you say, I mean, discounts, it would be, remember this is going to be allowed amount of spending. This is before any
So it's what the insurer has said that they're willing to pay, not what the hospital is asked to be paid.
No,
So that's the first one.
Right.
And then on the drug stuff, we know there's probably rebates going on that are near impossible to capture.
We don't have any rebates in this data.
Right, you probably do, you know, it's not, I mean, it's just, you don't see that the insurance company got whatever.
But we don't actually have the
payment for Pfizer for, you know, their insulin wasn't $400 a bottle, it was $375 because their people bought a lot of Lilly insulin. I'm just saying that when we think about how to track drug costs, it's always this problem of, as our colleagues have said, there's all these different arrangements that you can have in terms of, you know, is it a capitated? Is it a rebate situation? How do you want to do that? Totally understandable in terms of the market dynamics of what they deal with. You know, if I'm a drug company, I'm not going to offer you a 25% discount unless you can deliver lots of volume. Why would I? I'd be nuts to. So that sort of stuff. But it's always perplexed us in the past on these data systems that that's all just blind to us. We only see that list, you know, the allowable amount is for I think that's what we were referring to Bob before about the biologic, you know, that it's gone from $100 a bottle to $400 a bottle in a very short period of time. So we don't see that smart insurers go, but we have an awful lot of people using a lot of insulin, so we should get a discount. And you know, the drug company going, well, as long as your people buy at X level, we'll be happy to give you the discount. And we just never kind of can capture that in terms of, without micromanaging all those different payment arrangements. We just never know. So I'm just saying our drug data may be, it's just missing that last adjustment.
Right.
Okay.
But everything else is really what is actually paid, not what is asked to be paid.
So, yes, absolutely. Yeah.
Perfect.
Director Stefan?
So there is, for those that have an appetite for more data, the full report is coming. We're somewhat tuning it to some policy issues we know are coming down the road, particularly as it relates to disease burden. We do have some data on the growing prevalence of diabetes in all of the privately insured markets over, not dramatic, but it is upticking to a couple of questions there. And we do, in the full report, try to address risk in a bit more direct way. Certainly, the debate that's now going on regarding the establishment of the risk pool in the individual market, particularly between challenges that CareFirst says it faces versus challenges that Kaiser said it faces, really collide with two issues. One, the differential impact of the premium tax, which is sort of beyond our purview, but definitely the differential impact of risk in each of those respective payers' markets. With CareFirst, contending that we're getting a much sicker population. Kaiser contending, wait a minute, we are more effective in managing patients. Our care model is more efficient. I think we are going to have some answers on that over the coming months on how that splits out. Certainly, both of them, questions that we've asked is, certainly from the standpoint of CareFirst, most of the really sick people are in the PPO product. Commissioner Sargent, I'll stand corrected if I'm wrong. And from the standpoint of Kaiser, what if they are largely contracting with 5 hospitals, largely community hospitals, and not the academic medical centers? Do we expect that really sick people are going to sign up for a plan in which they don't have easy access? I would carefully qualify that and say there is access, but it's a much more of a review process that has to go on. And I think we can challenge both payers on to think about their models, both from the standpoint of their more efficient options, but also perhaps more flexibility in the tightly managed Kaiser model, where there may be not sufficient access to very complex medical care.
Okay, thank you. I don't think there are any questions. Ken, thank you very much. It was a great job, and thank you for all of your hard work, and thank you for your patience.
Thank you very much.
Okay, thank you. All right. The next item is focused on electronic advance directives, recognition criteria, COMAR 10-2519. Requires the Commission to approve the criteria to assess an application of an electronic advance directive service for state recognition. Commissioners, you've all received the proposed criteria in your meeting material. Nikki Majewski, the Chief of Health Information Technology, is going to provide an overview of the state recognition criteria, and after that, we will have a vote to approve that criteria. Nikki, thank you so much, and welcome.
Thank you. Good afternoon, Mr. Chairman, Commissioners. So Last February, 2 months ago, we brought before you the final regulations for Comart 102519, which became effective last month on the 12th. State recognition is a component of the statewide advanced directives initiative that aims to increase access to electronic advanced directives. It is a prerequisite for a vendor to connect to the state designated HIE. Just some background about how we formed this criteria. In 2016, we had formed a criterion connectivity work group to discuss policy matters related to advanced directives, and those recommendations were used to form the draft criteria. Some key elements of the criteria include mostly centered around privacy and security, for including procedural and technical controls such as authorization and authentication, administrative, physical, and technical safeguards required by HIPAA and HITECH, and including any transfer methods of the data if a vendor goes out of business or merges with another company, including notification to consumers, and any kind of notice or identification of circumstances where data might be sold or shared, as well as disaster recovery, business continuity, and cybersecurity plans. For independent audits, vendors will be providing a copy of their SOC 2 Type 2 audits and any remediation plans to address any findings in those audits. For technical, maintaining a secure web-based application, ensuring remote identity proofing, allowing video recordings, and the ability for consumers to store paper-based advanced directives that exist largely today. Ensuring they collect key demographic information to enable CRIS to appropriately match patients, and then track information on who accesses those advanced directives. Yes.
Can you just expand on the video recordings a little bit? Patients are allowed to record video of their own?
So back in 2016, when the law passed, this is one of the unique things about Maryland. It allows for a video recording to be recognized as an advanced directive.
What confusion could result from that, I wonder?
I was going to say, is there like a specified format, or do they wind up having to parse?
So it would still have to go through these kind of security protocols to verify that I'm Nikki Majewski and I submitted this. It's the same sort of process, but
Yeah, but when you talk about advanced directives, it's the video, the conversational piece of what goes back and forth with somebody is instructive from a subjective and societal standpoint, but from the technical standpoint of yes, no, would proceed with care, it seems like it could very much cloud a decision more than it could clarify a decision in some situations.
Which is
nice if it was there to supplement what's written, but not to replace what's written.
So in the law, the statute specifically says that certain key elements of the criteria must include, and this was one of those.
Has to include the video.
Yeah.
The ability.
So this is one of the things that was established, but in some ways we had to include it.
But the legislature has a higher authority than we do.
Somewhat.
So they have templates that they answer, do they have templates that they read from and answer the questions?
So no, Maryland law doesn't really require a specific form like the MOLST form does. It's very specific. So we're not baking in any requirements for vendors to include a certain form or another.
The hospitals keep their lawyers on staff for a while.
Okay.
Any further questions? Continue.
Okay, and then making available only completed advanced directives and allowing consumers to delete those advanced directives if they wish. For reporting, MACC will request they provide the number of unique advanced directives that exist for Maryland residents and how many times they've been queried by CRIS, using CRIS, and then any instances of a breach.
And then as far as education content for consumers, kind of scope of services, warranties, and any costs related to those services. And then lastly, for connectivity to Chris, just the procedural technical kind of controls for allowing that connection to happen. For public comment, we released this draft criteria last month, and it was in the Maryland Register and our website. We received one comment in support of the criteria from the Maryland Hospital Association. So we ask you today to adopt this proposed criteria as final criteria for state recognition. And if you have any other questions, I'm happy to answer them.
Yes, Kathy?
For data breaches, what is the requirement for communication to the consumer, communication to the Health Commission, and then communication to the public? I'm assuming there's none to the public.
So there is some information on that in the regulations, I believe, around, I think it's like 10 days with on or before the 10th day that we're notified of the data breach, and that would be a requirement.
On or before, that they're aware of it internally.
Yes, once they become aware that there's a data breach. So, I mean, perhaps it happened a year ago, but they upon discovery of that breach.
Okay, and that's to the Healthcare Commission.
Yes, and then
And then to the consumer.
yes, there's protocols for informing the consumer as well.
And how long is that?
I believe it aligns with the current statutes already in place. I'd have to go back and check the regulations. I think it's placed in there, and I'm sorry, I can't recall off the top of my head. But I think it's within 30 days. But I can follow up with you to clarify just to be sure.
And if the sort of pool identifying personal information on the person, I'm actually going to have to be able to make sure that they hire the right person to do it correctly.
Oh, absolutely. That's part of that
Name, address,
demographic.
security number.
Yeah, so.
That's really an excellent idea. Listen, I want to, Dr. Sharp, David, I'd like, if you have a moment, could you comment on this issue about the video presentation of an advanced directive and its acceptability? I think we need a little bit more clarification, understanding of exactly how this works, and you know, and the state legislature, of course, is the state legislature. They have told us this is the law. Those of us who are involved in this business would like to sort of understand.
This Uncle Joe at the 4th of July picnic says, pull the plug if it comes to it, or, you know, what?
Now, where does this come from?
Where does it, yeah.
So these are very good questions.
Thank you.
Let me start off by saying there is no way to be 100% both on paper and electronic. So you have to start from that premise. That both, what we've learned over the years is that both can be spoofed, even when you have notaries and witnesses and the like on paper. It ultimately comes back to the discretion of the providers, whether they trust them or not. The video has emerged as the digital age has evolved, with the concept being that if my wishes are recorded and I have a place to store them, I'm of sound mind, I'm appropriately positioned, I want to tell you as my treating provider what I want. The Karen Quinley case may come to some of your mind. And it gives me the ability to put that out there so you don't have to ask my kids, my spouse, my parents. You know it because you're seeing my face, so the biometrics is there. I'm able to make it clear what I want at a time when I'm of well-being. So the whole notion of using the cloud-based technology was to allow for digital media to be stored by a vendor who is credible, who meets all kinds of requirements, and where these vendors use they use witnesses, if you will, agents. They call them delegates. Where if I want to register my advanced directive, I identify some delegates. that the organization then goes out to and contacts and says, can you verify that this is who they say they are, as a way to substantiate it. It doesn't eliminate 100% the risk, because I think to Dr. Grady's point, there could be someone standing off camera with, a gun to the head of Fluffy the dog, and you'll say anything you need to. And that concept prevails, but can't be ruled out completely. So this solution is a way to support digitizing information. It is no 100% guarantee, and it's never intended to be. It just creates some impetus for trust. And ultimately, it goes back to the providers, just the same as with a MOLST form. All providers generally check with the families, and advanced directives is much the same way.
Is there an expiration date on the videos? What I'm worried about is Uncle Joe decides to post a video about his intentions, and they sit online for 10 years, and he forgets that they're there. And over the course of that time, he changes his mind. Sure. And he makes his new will known very clearly to those around him. And he gets to the hospital, and we look online, you see his video that's very clear in one direction, and his family says, no, 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 you don't understand, that's not what he wanted. And now you've got some conflicts of interest there always, because you can never figure out what's going on. The hospital's got its own conflicts, right? Every bit of life-sustaining care that it offers him, it doesn't get paid a dime more for him.
That's correct. So the answer is yes, but it doesn't really eliminate the problem you just stated, because each year these vendors reach back out to me, who with my electronic digital advanced directives, and say, it's time for you to update it, or say that there's no updates that are required. But if I change my mind mid-year and I haven't updated my advanced directive or been told to update it, it's still back to the issue of the provider and the family.
Do we specify in the regulations how often the vendor has to reach out to verify it? And what happens if there's no response from the part of the patient on the verification?
So the regs aren't specific on that detail, but what they are is specific on the criteria for assurances. And in this case, as you've noted, there's only a small number of advanced directive vendors that offer video. In fact, I could probably count them on less than one hand with a couple of fingers. And what they do is if it's not authenticated, they remove it. And so that's the quickest way they handle it. If you each year aren't able to substantiate it, they take it down. Yeah, it's every year.
Okay. Thank you very, very much, David. Yes, Dr. Thomas.
You remind me of something my mother said. She said, you better hope I go first, because I said, cremation. She said, you better hope I go first, because nobody's going to burn up my baby. So my point is, when family members get involved, no matter what actually happens? You may not know, but I'm just saying, it's an issue.
Well, it remains an issue, and I go back to Karen Quinlan, right? I mean, there was, her husband couldn't, the family and the husband disagreed, and subsequently she was kept on life support for a long, long, long period of time.
You mean to tell me we have not advanced beyond that possibility happening again?
Yeah, we have.
I think what we have here is not going to eliminate it. Okay. I think we refer back to the clinicians who ultimately work with patients and help make these choices or move the decision-making process further along.
Yes, Dr. O'Connor.
Well, an advanced directive can be changed at the last minute as long as the patient is deemed competent. Even though his body's failing, if his mind's competent, he can change on his deathbed despite any video.
That's it.
But if he comes in unconscious and is an advanced directive, the family's totally discounted.
Well, all right. We're not going to debate the facts here, because I think that's the intention. Let me ask you this. In terms of these criteria that we've got here, last time we discussed this, Nikki, I asked you whether, in fact, other states had developed the degree of sophistication in this area that we have, and I think your answer was that not quite. So we're pretty much at the head of the curve on this whole issue, isn't that right?
Maryland is. I mean, some HIAs are exploring it, but integration is more.
Because, Dr. Moffat, what's at hand here is integrating the advanced directives with the HIE. These electronic vendors exist anyway, and you know, in some states they're more, they have greater market penetration than others.
Yeah, and you know, Dr. Sharp, you basically clarified, you know, a fundamental truth that was recognized years ago when the President's Council on Bioethics actually addressed this question. It was a remarkable study, and they made the point that, you know, frankly, advanced directives are imperfect. I mean, people can change their mind, you know, as Dr. O'Connor points out. But the fact of the matter is, we have very few, I mean, relative to the general population, too many people are not thinking about this.
That's right.
And that's why we are in some of the trouble we're in, especially in Medicare and Medicaid, where we have a lot of people who are simply, we just don't literally know what to do. So it's a serious problem. Okay, well then yes. Are there any further questions? One more and then, yes.
Not so much a question as commentary.
Right.
I'm very intimately familiar with the advanced directive process, more than I ever hoped to be in my entire life. Working in long-term care, where we are at the cusp of end-of-life care and these types of decisions. Maryland is ahead of the curve, thanks to some of the work within the AG's office to streamline the forms that we use. There's still quite a lot of folks out there that have attorney-drafted forms, the older type forms, et cetera, and they're all still legally acceptable. It'll be a challenge to bring this forward electronically. I hope that it produces favorable outcomes. With that said, the advanced directives are only as good as those people that follow them. And what I mean by that is we have experience where residents will go out to acute care facility, advanced directive is sent with them because it's not electronic at this point, and the resident is incompetent. The resident may not be able to voice their concerns, and the family's wishes conflict with that advanced directive, and almost without fail, the physician in the hospital will follow the family's wishes to protect themselves. And then, so typically that means some type of artificial hydration or nutrition is placed into that resident. They return to the facility right away. That puts us in a bad position. We have to review that advanced directive right away. It cost us multi-thousands of dollars to talk to our counsel to get advice on which way to go. We had to convene a patient care advisory council committee immediately. Hopefully, we're able to work with the family to follow the resident's wishes as are outlined and documented in that advanced directive. Because we're findable by OHCQ. I mean, I'm liable, my license is liable for not following that person's advanced directive. If the family comes, for lack of a better term, in line, and we follow the resident's advanced directive, then it goes away. I've had a few instances over 25 years where a family still doesn't want to follow that advanced directive because they feel like they're starving mom or dad or their uncle to death. And the process that's followed in Maryland is an involuntary discharge notice to that family that we will care for that resident until such time as we can find a facility that will follow your wishes. But we are required to issue the involuntary discharge notice to protect ourselves because technically we're violating that resident's wishes and in violation of the law. So, I could talk a long time about this because I've been in these cases a lot of times. I'm chair of our area's patient care advisory council, and it's a delicate area. Hopefully this will help improve that process, but
even the electronic version will only be as good as the people that follow them. So I just wanted to make those comments.
Right.
Thank you.
Thank you very, very much, Commissioner. And I think, given your experience, that really helps. That helps to inform our decisions. We're trying to make progress here. This is a very, very difficult area. We all know that, and there are profound moral and ethical divisions in many cases on these kinds of questions. In any event, are there any further questions? All right, then the motion is to approve the electronic advanced directives, the recognition criteria. Do I have a motion? I have a motion. Do I have a second? Second. All those in favor say aye. Any opposed? Thank you very, very much. Nikki, thank you very much. Dr. Sharp, thank you very much, as always. Our next item is a presentation on the Medication Management and Reconciliation Grant Award, creating and maintaining accurate patient medication, can improve patient medication and limit potential errors, adverse side effects, interactions, excessive costs, and a lot of other things. Joining her at the table, is Eva Lenoir. Excuse me, Eva. Joining you at the table is Dr. Stacy Garrett Ray, President of the University of Maryland Quality Care Network, and Dr. Magali Rodriguez de Bittner. Is that correct? Oh my goodness.
Oh my goodness. I was waiting for a version, but you did great.
Thank you. Yes, I can be taught. Okay, Professor and Associate Dean for Clinical Services. Okay. And Practice Transformation at the University of Maryland School of Pharmacy, Executive Director of the School Center for Innovative Pharmacy. Oh my. Eva, thank you very much, and the floor is yours.
Great, thank you. So as you may remember, in November of last year, the Maryland Healthcare Commission released an announcement for grant applications to advance medication management and reconciliation through telehealth. We received 13 letters of intent and 7 applications. With the assistance of external evaluators, which was comprised of physicians, pharmacists, and representatives from CLIPS and Maryland Medicaid, 2 applications were considered. The University of Maryland Quality Care Network was selected for funding. The goal of the project is to demonstrate the impact of using telehealth to optimize medication-related services in care delivery by improving the quality and completeness of medication lists through the support of pharmacists, and this would help providers to better manage the therapeutic regimens of their patients. And UMQCN will also be utilizing the state-designated HIE CRISP in order to increase the awareness and availability of reconciled medication treatment. And we believe that hospital systems are of great value when it comes to expanding and piloting these types of telehealth projects. As of 2017, approximately 88% of hospitals have implemented one or more telehealth projects to support their internal activities. Hospitals are generally well positioned to develop and pilot test innovative telehealth projects because they're able to leverage their existing infrastructure, both administrative and financial infrastructure, to support the deployment of these types of projects. They also tend to have more flexibility in their operational budgets to provide grant matching funds compared to other provider types. And this flexibility is actually crucial because the cost to acquire, implement, and maintain telehealth services is one of the top challenges in establishing a successful telehealth program. And lastly, they tend to have more support to expand and scale up these types of projects. And by awarding telehealth projects, we have the opportunity to assess the effectiveness of telehealth along various types of technology, providers, clinical settings, and clinical protocols. And we can then share these learning lessons from these projects to stakeholders both locally and nationally. and these can then in turn help to inform better practices and industry implementation efforts, potential policies to be taken into consideration to advance telehealth, and existing and future telehealth projects across the state. The objective for this newest grant is to optimize medication management and reconciliation using telehealth to improve care coordination and health outcomes for Maryland residents. The project would leverage telehealth and HIE capabilities to expand pharmacist support and assist healthcare professionals to better manage their patients' medication. The grant will operate from April 2018 through October 2019, and about $329,000 will be dedicated to the grant. We think that this project will be highly valuable. Medication errors are a leading cause of patient harm, resulting in about 10% of total hospital admissions nationally and costing up to $50 billion annually. Non-adherence to prescribed medication contributes to poor therapeutic outcomes, progression of disease, and excessive healthcare costs, which could be, some of them at least, to be avoided. And so creating and maintaining accurate patient medication lists can improve adherence and reduce the potential for these types of errors and adverse events. New models of care delivery consider pharmacists as key participants in a multidisciplinary care team, and these pharmacists can then make sure that the patient's medications are up to date and that there are no negative interactions within these medications. And this can be harder for smaller practices to provide this kind of medication management. The project will increase access to a pharmacist in a primary care setting through electronic visits. The targeted population consists of patients with comorbidities, high-risk medications, patients who have frequent readmissions to the ER, or our own pain management medications. Specifically, this project will be targeting patients with COPD. And in collaboration with CHRIS, the UMCCN will be piloting a process to send reconciled medication lists for these patients to CHRIS so that they can be made available to other healthcare team members within the care team via the Prairie Portal and CNS. And before I turn it over to Drs. Garrett Ray and Rodriguez de Bittner, I would like to just recognize some other members of the project team that are in the audience with us today. Dr. Mark Dubrow, the Vice President of Telemedicine, Medical Director of eCare, and the Associate Professor at the University of Maryland School of Medicine, will be the Technical Manager for the grant. And Roxanne Zagab, the Director of Operations and Business Development at the University of Maryland School of Pharmacy. So we're very pleased to have so many members of the project team with us today.
Oh, welcome to you.
Thank you. We also have Mark Falcone, who's our Director of Operations, as well as Kimberly Taylor, who's one of our project managers with Quality Care Network. So, I just want to say thank you so much. We are truly honored to be granted this award. We're excited to get this launched, and so truly thank you. So on the next slide, so just sit down there. Just wanted to go over some of our collaborating groups that we have. So again, Quality Care Network, we are pretty much a clinically integrated network focused on value-based care within University of Maryland Medical System, as well as we work with other partners throughout the state as well. To my left, Dr. Magali Rodriguez de Bittner, who's always my partner in crime on many innovative strategies with the eHealth Center for the School of Pharmacy, University of Maryland School or Medical System, telemedicine programs, and eCare with Mark. Our community medical group on the Eastern Shore, so those are our community physicians with the Shore. We also have an advisory board that is comprised of our physicians on the Eastern Shore, as well as our practice managers, and also the eCare program, in addition to Chris, who we're looking forward to working with on this initiative, as well as our high-risk patients that we have identified who have the diagnosis of COPD. So briefly, I just want to go over the project description and what we're expecting to be able to do with our project here.
So the medication therapy management as well as our electronic medical or medication reconciliation project is really here to enhance how we're providing care, overarching for the patients that we've identified with COPD in rural Maryland. We're hoping that this is something that will be scaled and something we can utilize throughout the state and be a model throughout the country with our team and our partnership, but to enhance a lot of the informed decision making that's necessary for our providers as well as our patients in terms of the development or the delivery of care for our COPD patients. In addition, being able to provide real-time information and data pertaining to our medications that we're giving to. So that's one of the things that we see is that a lot of times there was the recurring admissions and readmissions and utilization and high costs. It's not that people don't want to improve. Sometimes it has to deal with not having the availability of medications, or the other component is not having the understanding of actually the disease itself as well as how to utilize their medication. So we're hoping with this we'll be able to deliver these services in terms of medication therapy management via telehealth as well as our virtual clinic technologies. In addition, being able to share that information with our patients and providers, utilizing our EMR, our electronic medical record with Epic, but as well as CRIS, I think will be beneficial in creating workflows, as I stated. That one, we can scale in other areas, but also look at other chronic conditions where this can be utilized.
I wanted to very quickly highlight what do we expect from this project. And as you heard, really the main goal is to have a pharmacist that is available not only to the physicians for consultation, but really get very involved with MedRec, but also medication therapy management with these patients. So as such, we predict that by doing so, we will improve medication adherence by patients understanding better the medicine and being able to overcome some of the barriers that they may present to us. We also will provide some patient self-management. One of the things that we all know about conditions like asthma and COPD is that those require the use of inhalers, devices, and a plan that we could be able to reinforce with our colleagues, with the physicians. And we're thinking that we would probably, based on the population we have in these practices, our target is about 100 patients that we will be deeply intervening with. As such, in the QCN, we have the luxury that we do have data for these patients for both medical costs and pharmacy costs. So we are going to be doing a pre-post looking at, again, how are we affecting not only overall total healthcare costs, but also acute healthcare costs, reducing emergency room visits and hospitalizations that are directly related to COPD. In addition to that, one of the main goals of this grant was really testing the ground. How can we incorporate within the electronic record, but also with CRIS, accurate, the latest med list and medication reconciliation for that patient. And the idea is that that will not only affect the care that they're receiving in this particular primary care office, but hopefully it will impact the care of these patients no matter where they go. Because if this list is accurate there, an emergency room physician, anyone taking care of this patient should have access to that accurate list. By the way, that also includes not only prescription meds, but when we do the MedRec, we include over-the-counter herbals and any other medications that patients are using. And again, the whole idea here is really testing the technology and testing the process and that collaboration between those entities. The last page, what we wanted to do is just give you just a preview of some of the different tools that we're going to be incorporating and the different partners that we're bringing to the table. And so I just wanted to highlight one that is called Zoom. And this is just the technology that we're going to be using for this virtual clinic. And again, the beauty of this is that it doesn't require fancy telehealth equipment or expensive. Our goal is to really use smart technology. So individuals that may have a smartphone, tablet, a laptop. And we also are going to test, for those patients that don't have it, lending patients some of these tablets to take home. So we could conduct some home visits and really assess the home environment. So that's it.
That's it, right?
That's
Well, you have next steps. That's not it.
That's the next step.
April 2018,
Yeah.
you launched the project. This is over in terms of releasing the final outcomes on September 2019. So you got a lot of work ahead of you. But I'll take the chairman's privilege. I think that it's very, very clear in health policy today that telehealth is perceived to have tremendous potential. As you know, and you probably do know, many of us who follow this sort of thing, recognize that one of the rare, in this environment in Washington, one of the rare bipartisan agreements was the Hatch-Wyden agreement to address chronic care, which relied, if you looked at the provisions on it, it had a very, very strong telehealth provisions in the bill. The focusing on chronic illness, primarily diabetes, but of course, you know, with Medicare, you're dealing with chronic illness, you know, enormous amount of problems there. But in any event, as a matter of public policy, one thing that I feel very strongly about is that there are, a body like the Maryland Healthcare Commission will give a grant, and this will be done in the name of the public interest. And sometimes, not always, but sometimes the results of this effort will be absolutely terrific. And it will be then on a library shelf somewhere. Nobody will know about it, except some doctors talking to some other doctors in the hallway at Anne Arundel Medical Center or Johns Hopkins or whatever. What I would hope you would do is at the end of this, think very, very long and hard about getting this into the public domain. And I will make a suggestion that you think about Health Affairs, which is the most prominent health policy journal. We did this with regard to the price transparency initiative that we had for hospitals. And I can tell you the impact of the Commission's effort in this area is now nationally known. Telehealth is going to be a very, very big part of the future, simply because of the tremendous need for people, especially in rural areas, to get the kind of assistance that they need from their providers. So I would hope, you know, when this is, you know, again, we have people on the staff who will help you with this, but I would hope at the end of this process that we'll have a product that we can approach. You know, maybe we can help you with it or some way, but we can approach Health Affairs to do a nice study saying this is what we did, this were the accomplishments. And I know those guys, the editors there are very, very strict when it comes to the precision of data and methodology, you can imagine. I mean, but the point is that this is something I would ask you to keep in mind. So if you're helping patients, that's the most important thing. But if we are actually, you've got some very, very nice goals here. And if you achieve them, we have got to make sure that other people in the policy community and other public officials like us in other states have some idea about how successful you have been. Okay? All right.
I want to add
Commissioner
on in addition, the fact of the matter is that this is being financed through the citizens of the state of Maryland, and getting this information out into the public realm for the citizens to debunk the fear within older populations about the use of telehealth, but also to spur innovation for the future and to get others to use it, I think is equally as important. And it's not just in the public realm as far as the media, but also for our legislators to endorse the idea and move forward. So if you could please, I know you're going to be successful, because when you can't breathe, nothing else matters. Please work towards that as well.
Right.
Thank you.
Commissioner Sargent.
I wanted to ask about the video aspect of this, because you can do, I think, every element of this program over the telephone. In fact, we have a program, Care First, that basically does exactly that. We have integrates the medical record, speaks to the physicians, speaks to the members, looks at all the pharmacy data, recommends adjustments to medications to the providers, accept or not accept. Is there some point at which you're going to try to measure whether the video is more successful than the existing programs that use the telephone, and how would you determine that?
One of the reasons we picked the COPD population for the AZ encounter is that the estimates are 60 to 80% of that patient population uses their medication incorrectly. And part of this program is to actually watch them use their inhalers, watch them use their devices. Show me your oxygen tubing. Is it clean? Is there mold in there? Humidifiers, all that stuff. Walk us around your environment to make sure you're not tripping over things, over your oxygen cord. So, in fact, there was considerable method to the madness of picking this particular patient population with exactly what you're asking in mind.
Thank you, Doctor. Director Steffen.
So I did want to make sure that commissioners know that the University of Maryland at Baltimore, both the School of Medicine, the School of Pharmacy, the School of Nursing, have been very collaborative partners on a number of projects. Going back to the multi-payer PCMH program, a host of publications have arisen from that work, and I think we are probably figuring out how we elevate that in the broader media is something we'd be interested in working with you on, focusing on this project as well. Probably the most effective, and recognizing that publications for academics do come with additional benefits, but we really appreciate the work that you've done with us in the past, Dr. Khan and others, and just want to note that Melanie Cavalier and Dr. Khanna will be giving a poster presentation at Academy Health on the Practice Transformation Network this year. Jill Marsteller, still harvesting the multi-payer PCMH evaluation, will also be presenting at Academy Health. And although we're indirect collaborators with Mathematica on the assessment of the care, the CCM payments, which was an innovation launched a couple of years ago with varying success. We've been a long time at least interested in how that's rolling out. So, but the University of Maryland stands out among many in terms of being very attuned to sharing, working with us to make certain that results are publicized. We look forward to continuing to work with you. I think the point that Dr. Moffitt raises, though, is an important one, that we need to think about how these telehealth initiatives get taken to scale. We've done a lot of them, and they seem to be successful, but we need to figure out as we report on these successes how they are expanded going forward, if successful.
Are there any further questions at all? Commissioner O'Grady, you have nothing to say. Have that for the, would you please record that for the record? A quiet Irishman. Happens. Thank you very, very much. Thank you very much, Doctor. Thank you, lady. Thank you very much. We look forward to working with you. Okay. The executive director is going to tell us about the work initiatives that we have coming up, what will happen in May at our public meeting, and all of our obligations to the good people of Maryland.
So thank you, Mr. Chairman. And I've noted work of the CON task force. The task force will be meeting tomorrow at 9 o'clock here. We also expect that the draft interim report will be reviewed with the Commission in May. We also expect another telehealth award on medication assisted treatment for opioid care. We hope to have enough momentum on our Maryland primary care program to talk about our plans to establish as part of that Practice Transformation Network initiative. Of course, we will have several CONs, and because we haven't heard too much from Eileen Fleck recently. She is going to be called up for a rare presentation next month. Actually, I think the first of a series of our certificates of ongoing performance for cardiac surgery. The first 4 programs will be reviewed. This is a long-standing effort on the part of Eileen, Paul Parker, Sue Ellen, and others to establish this program of ongoing oversight of cardiac surgery and PCI. And these are the first 4 that will undergo this review. So we'll be interested in those results and also the commissioner's thoughts on this regulatory responsibility that we have at a time when we're also thinking of modernizing. So I think it would be I also wanted to say that one thing that did come up in questions from Megan is that we may think about how we bring everyone up to date on the ICN, the Integrated Care Network, a major IT initiative launched under the aegis of HSCRC, but because we are the overseer of CRISP, we do monitor the funding, but I would, if we have a moment, spend a bit of time on what those investments are going to buy residents of the state. So try to do that in one way or another over the next couple months.
Thank you very much, Mr. Director. All good things come to an end. So I would like a motion to adjourn. One move, okay. Second, very good. All those in favor say aye. Nobody wants to stay. Okay, thank you. The meeting is adjourned.